All right, everybody. So we're just about to get started. I'm just watching the participants build on our screen, and I'd like to welcome everybody and thank you for joining us here today. Just wanted to remind everybody that if you can ensure that you are muted, just to reduce any background noise, that would be great. A reminder that you're joining us for a very special presentation on behalf of World Spine Care. The topic is pain and related disability, making the vulnerable more vulnerable. We're pleased to be here as part of the 2020 Skull Virtual Forum. So my name is Stefanie Ince, and I'm the Executive Director of World Spine Care. World Spine Care is a global charity on a mission to improve the lives of people in underserved communities. World Spine Care aims to create a world in which everyone has access to the highest spine care possible. Today, I'm very pleased to be co-hosting our panel discussion with my colleague, Dr. Margareta Nordin, who is the former president of World Spine Care Europe, a member of World Spine Care's executive committee, as well as one of the principal investigators for the Global Spine Care Initiative, which is something that we'll be learning more about later today. I encourage everybody to introduce themselves using the chat function, and I'm going to first launch a short poll just to get to know you all a little bit better. So here we go. Hopefully you guys can see that. I'm going to give you a few seconds to answer the poll. And I'm seeing the answers coming in. They're still coming. So we'll just give them a few more minutes before I close the poll. So you'll notice that the questions that we've asked is, how many people joining us today have back and or neck pain, or have loved ones who have back or neck pain? We're asking people to click yes if they do and no if they do not. And the second question is around the impact of neck pain. So I'm going to go ahead and end that poll and share the results with all of you now. So hopefully you're seeing that. Not surprisingly, and very much in line, I think, with what we're all here to talk about today, a huge percentage of people who are attending this conference, 96%, either themselves experience back and or neck pain, or they have loved ones who do. So in terms of prevalence, this is highly topical. And regarding the impact, when we ask about those who have back or neck pain and what kind of impact this pain has on life, at this point, 85% of poll respondents say that either that pain is significant or some pain. So without further ado, I'm going to get started. And I'd like to first allow our panel to introduce themselves. So I'm going to go ahead and ask Pierre to get us started.
Good morning, good afternoon, good evening, everyone, wherever you are in the world. First, I hope that you and your loved ones are healthy and well in these very difficult times. My name is Pierre Côté. I'm a professor of epidemiology and public health at Ontario Tech University in Canada, and I'm also the Canada Research Chair in Disability Prevention in Rehabilitation. Pleased to be with you.
Great, thanks, Pierre. Scott, do you want to go next? Oh, Scott, you're muted.
Sorry, I want to reiterate Pierre's concerns about everybody and wishes that everybody is keeping themselves safe and in somewhat isolation, although I must admit the Zoom has made a big difference in our feeling of isolation. I'm co-founder of World Spine Care, and I'm very proud of this group that we have here today, which I think is fantastic. I'm also a clinical professor in Department of Neurology at the University of California, Irvine, and adjunct professor at a number of universities, including epidemiology at UCLA and health sciences at Ontario Tech University in Canada.
Great, thanks, Scott. Moving on to you, Jan.
Hello, everyone. My name is Jan Hartvigsen. I'm a professor and research leader at the University of Southern Denmark. I'm a clinical epidemiologist who have done research in spine and musculoskeletal pain and disability for many years. I was part of the steering group and the co-chair of the Lancet Low Back Pain series that was published a couple of years ago now, and I've been involved in the World Spine Care Research Council for some time in supervision of master student and PhD students associated with the World Spine Care program. So very pleased to be here today. Hello, everyone.
Thanks, Jan. And over to you, Rajani.
I'm Rajani Mullerpatan, and I'm the clinical director for the Mahatma Gandhi Mission's World Spine Care Clinic, which is located at the MGM Teaching Hospital in Navi Mumbai, which is a twin city of Mumbai. And this hospital is a charitable hospital which caters to the underprivileged people in its catchment area. And at the University of Institute of Health Sciences, I'm a professor and director of physiotherapy and human movement science. And wish you all a great evening, and looking forward to discussing and talking to you about this very problem, which I think gets pronounced when we all are at home now.
Thank you, Rajani. Turning things over to you, Steve.
Hello, everyone. My name is Stephen Lasky. I'm a chiropractic physician. I've been a volunteer and member of World Spine Care for the past 4 years on and off. I originally began volunteering in our clinic in the Dominican Republic site for some time in 2017. And then most recently, I have been involved with our Botswana clinics over the last 9 months as the current clinical coordinator. I'm happy to be a part of this group and looking forward to a great discussion about all this today.
Thanks, Steve. And last but not least, we've got you, Vincent.
Hi, I'm Vincent Setlhare. I'm a family physician. I'm head of Department of Family Medicine and Public Health Medicine at the University of Botswana. I've been associated with the World Spine Care for the past 4 years, and I look forward to having a good discussion with everybody. Thank you.
Thank you, Vincent. I'm just going to say a few more housekeeping items. We'll talk a little bit about format, and then we'll dig in. So again, a reminder to please feel free to use the chat function to introduce yourselves to each other. A reminder that this presentation is being recorded and it will be made available to you after the fact. As well, we are currently broadcasting on Facebook Live, so hopefully our message and the great discussion that happens here will be extended to a broader audience. Just in terms of a reminder on format, we're going to dig into some pre-developed questions, which my co-host Margareta will be leading. But following that, we will ensure there is time for sufficient Q&A. So I encourage you throughout this session to use the Q&A function to ask questions as they occur to you. At the end of the predetermined questions, there will be plenty of time for us to answer any questions that you may have. And so without further ado, I will turn things over to you, Margareta.
Thank you, Stefanie, and good morning, good afternoon, good evening to you all, wherever you are. And as you know, we are very fortunate to have some of the most well-known musculoskeletal experts in the fields joining us today, and we'll start the discussion, but just a few words on behalf of World Spine Care and our panelists today. The global burden of disease, the Global Spine Care Initiative and Lancet has stated that over 1 billion people in this world are partly or severely disabled. And the greatest cause of disability, of course, is specifically low back pain and neck pain that forms #1 worldwide and globally. So pain and related disability impact the most vulnerable people in the world. The women, the elderly, the lowest quintile of the population in the poorest nations. It also impacts well-being, quality of life and function. And in the end, it impacts the whole community in form of loss of productivity, stress on the healthcare system, support to the disabled person, loss of tax payment, and reduced family and community function. And of course, this makes the most vulnerable even more vulnerable. So World Spine Care is committed to reducing disability-related spine and musculoskeletal pain, and to develop a model of care to reduce the incidence and also the impact these conditions. So the panel will discuss and review the impact of pain and disability in these vulnerable population and current models to reduce the impact. And with no further ado, we will actually dig into the questions. And the first question goes actually to Pierre Côté. And the question is, what is the pain-related disability and how does it impact a person's life according to the WHO or the World Health Organization? Go ahead, Pierre, please. Do we have Pierre online?
Oh, Pierre is on mute.
Pierre, can you unmute yourself?
My apologies. Thank you very much, Margareta. So when we talk about pain-related disability, and more specifically today, back and neck pain-related disability, we are really discussing or describing how the pain manifests itself in people's daily activities. So when we define disability, we're actually talking about functioning and how individuals are able to engage in their daily activities in the presence of back and neck pain. Now, the WHO defines disability or inability to function optimally as having 3 main components, and these are the body structure and body functions that are impacted by the disorder or by the disease or the diagnosis. And that would be, for example, the experience of pain, but also things like back stiffness or inability to move, or being having extra feeling of pain in the body. But what is really important about the WHO model of disability is that it goes beyond the diagnosis. It goes beyond the medical condition and really looks at how people can actually engage in daily activities and participate in their daily lives in the presence of pain. So we now understand disability as having 3 main components: body functions, body structures, activity limitations, and participation in normal daily lives. But what the model is really telling us too, and what I think is really important when we think about disability, is that it goes beyond the person or the individuals and is very much impacted by community. So we know now that the environment can either promote disability or assist in people participating in their activities of daily living, reducing disability. For example, let's take an extreme case of someone who has quadriplegia and has to use a wheelchair. Well, these individuals might be able to engage in work. They might be able to engage in daily activities. But if there is no ramp to get to their workplaces, then they're unable to function there, to engage in their occupational responsibilities. So the environment which facilitates individuals' contribution to their role is very important. But we also know that back and neck pain disability is not only one condition. In fact, most individuals who have back and neck pain will also have mental health comorbidities or other disorders or conditions that will accentuate or accelerate the development of their disabilities. So again, when we talk about disability from a biopsychosocial perspective or the WHO model of disability, we're really talking about the individual, the environment, and how pain manifests itself in a person's daily life. Thank you, Margareta.
Thank you, Pierre. So the next question is to Jan. Why should we care? And as a society about pain and related disability, and how serious a problem is it, and what is its impact globally? Please go ahead.
Well, thank you. Well, back pain and spine pain is a much bigger problem than most people realize. And that's for two reasons. And the primary reason is that it is so common. It affects so many people around the world. And in most people, it's not very disabling, but it's a little bit disabling. But because it's so common, the total disability burden becomes very large. And then there's a small group of people that become very disabled from back pain. They cannot work, they cannot live a full life, they lose their function and their role in society, and they become completely dependent on other people. So, of course, that small group of people adds a disproportionately large contribution to the total burden of disability. And if you add that all together, we have over 60 million disability adjusted life years every year in the world because of back pain. And it's the #1 reason for years lived with disability in 126 out of 195 countries in the world. If the disability burden was moving in a good direction, if it was becoming smaller, there was maybe not such a big reason to be concerned. But in fact, disability caused by back pain has increased with over 50% in only 25 years. So in spite of all our efforts to decrease disability, it has actually increased. And we are seeing the largest increase in disability caused by back pain in low and middle income countries in South America, Africa, Asia, and the Middle East. And there are now new studies coming out of Africa to suggest that the prevalence of back pain is probably even higher in Africa than it is in high-income countries. So that was speaking about the total disability burden. If you look at the cost of back pain, that's also a burden that it places on societies and individuals. There are two types of costs. First there's healthcare costs that in high-income countries are very, very high for back pain. In fact, there was a new study published just a month ago that showed that back pain was the most expensive condition for healthcare systems in the United States. Almost $135 billion are spent every year for treatments for back pain. This is an increase of almost 7% every year. And this is happening at the same time that disability is increasing. So it doesn't look like we are getting very much for our healthcare dollars. In fact, there's emerging evidence that healthcare systems are promoting disability rather than increasing it. So a large proportion of these healthcare dollars are wasted. Now, the other big cost driver is, of course, work disability, because the disability from back pain is highest when people are in middle age, when they're supposed to be most productive for their families, for themselves, and also for society. And finally, we are learning more and more about how back pain affect individuals. We do that from qualitative studies, and there are now very many qualitative studies where people who have persistent back pain are telling us that it ruins their lives. They tell us about hopelessness, loss of social roles, poverty, dissatisfaction with healthcare, family strain, and depression, like Pierre talked about. So there's every reason to talk more about back pain and spine pain and to care more about it and to really change the way we approach it. So those are a few of the reasons why we should care.
Thank you, John. So our next question goes to Vincent in Botswana. Is pain and disability a problem in Africa and specifically in your beautiful country, Botswana? You have to unmute yourself, Vincent.
I work in a primary care setting, and my rough estimate is that a third of the patients that I see will have back pain as one of the problems that they present with. And it's mostly adults 40 years of age and over, and it becomes more and more prevalent as the years increase. And I want to think that it is becoming the reason why back pain is common is that people are lifting heavy loads, they work in the fields, they walk long distances, they are prone to injury, and vehicle injuries, road traffic accidents contribute, are in the top 10 causes of health problems in the primary healthcare settings. So things like disease, TB, and cancer also contribute a lot towards back pain. People, mothers who are expectant, pregnant mothers present with back pain a lot. Obesity in the urban setting, you find people with big stomachs and lordosis. They present with back pain also. And the sedentary lifestyle in the educated people and those who are well-to-do also contributes to a lot of back pain that presents in the primary healthcare setting. So in short, I would like to say that back pain is quite a big problem in the primary healthcare setting in Botswana. And I think that this holds for many countries in sub-Saharan Africa.
Thank you, Vincent. And we'll see that we have the same problems in all over the world. Well, our next questions go to Rajani. How does pain and related disability impact workers in India? Is it something that the Indian healthcare system is trying to address? You may have to unmute yourself, Rajani. Hello? Okay, we may have lost Rajani. So let's come back to Rajani and let's go to Stephen. Stephen, you have to unmute yourself, and here is your question. From a personal experience in World Spine Care clinics in the Dominican Republic and Botswana, can you give us some example how spinal pain impacted the vulnerable patients from an underserved low-income community?
Thank you, Margareta. So I believe patients with these spinal pain issues in the communities are actually impacted in multiple different ways. I think the foremost and most prevalent one is the area of just simple survivability and livelihood. And while this might not be the case at the forefront of all of our World Spine Care clinic sites, it's definitely the case for many, and it varies between them. So over the time that I've been able to treat patients in both the DR and Botswana, many of the patients are impacted to an extent that really limits them from carrying out their activities of daily life and their work-related tasks. These patients, who happen to make their livelihood either through farming or other heavy manual and physical labor jobs, are unable to perform the tasks that relate to them, which have a direct impact on their livelihood, financial incomes, and ability to support themselves and their families. This also has a tendency to increase the rate and prevalence of disability in these areas as well. And also in part that given a lot of the fact that patients who experience spinal pain, particularly low back, are coming from a lower socioeconomic status, this can directly translate to patients, women who are making their livelihood as housekeepers particularly. This is a big example that we have in Botswana. A large portion of patients we would have coming into the clinics are just like we mentioned, women in their 40s complaining of low back pain as their chief complaint. So these physically demanding tasks with repetitive movements, forward bending, lifting, things we would typically see in a lot of the clinics are part of the demands that increase these factors. The other thing we have to take into consideration is not only the biological aspect of disability that this is contributing to, but the psychosocial aspect of disability being affected as well. For patients who transition from that acute more towards the chronic state of things, it's the inability to cope or increase their self-efficacy in terms of return to work status that are affected by these things, and they tend to be a bit higher in these populations as well. Additionally, there's also the outright access to care for some patients with spinal pain that they might not have otherwise. Foregoing the accessibility that these patients might cause them to remain undiagnosed or untreated for a condition that might not otherwise be detected if it was not for the availability of a world spine care clinician or a world spine care treatment. So without proper referral and triage, many patients who I've done workup on ended up being diagnosed with symptoms such as cauda equina or multiple sclerosis or spinal tuberculosis that have gone unchecked through other avenues of the local healthcare system, or it might not have been appropriately managed. So making sure that we're another resource for these patients to direct them through the healthcare system is also another opportunity that we're able to contribute in reducing spinal pain.
Thank you, Stephen. I'm going to call for Rajani. Can you hear us?
Yes, I can.
Okay. Welcome
Hello.
back.
Yeah. Thank you,
So I
Margareta.
repeat your question. How does pain and related disability impact workers in India? Is that something that the Indian healthcare system is trying to address, for example, in Maharashtra?
Yeah, currently we do not have population-based studies reporting the impact of pain and disability on workers throughout the country. However, we know that pain and related disability interferes their daily function. Our own cross-sectional survey, which was from 6 villages in one of the largest districts of the state of Maharashtra in India, revealed that pain and related disability does interfere with function. And almost the figures of prevalence were the same as those which were reported by the Indian Council of Medical Research in India. That is, in the rural, we had a prevalence of 4.9, and in the tribal of 10% of low back pain. And in neck pain, we had 2.9 and 3.6% in tribal. The commonest activities that they reported that were affected were lifting heavy weights and trunk bending in their day-to-day work. However, observation is that these workers continue to work simply because they are not compensated for their time off. However, when it interferes with their daily work or it interferes with their occupational work, they take time off work and they seek treatment and then resume work back on. Some of the barriers that they have even in approaching the primary healthcare center like lack of transport facilities as one of that which delays their treatment even at the primary healthcare center. And now trying to answer the question, what is the Indian healthcare system trying to address? Currently, the healthcare system is heavily focused on infectious diseases such as latent tuberculosis, which is a huge challenge throughout the country. And of course, the focus is on improving maternal and child health. However, in certain states of the country, like in Maharashtra, we do have certain facilities, health facilities dedicated for Mathadi workers. Mathadi means workers who carry weight on their head. And there are dedicated hospitals to deliver care for musculoskeletal disorders. So that's where we are currently, and we hope that this is addressed much more with a greater focus to try and improve their daily function. Thank you, Margareta.
Thank you, Rajani. And we now go in the first round to the last question, and that is for Scott Haldeman, our founder. What are the most important factors that motivated you to establish the World Spine Care charity, and what are its goals?
Thank you, Margareta. The World Spine Care program is very personal. I've had the privilege of working in the spine world for almost 50 years. And many of the panelists here are amongst some of the most prominent researchers that I've had the privilege of working with. And it's very interesting when you're working in a Western country like the United States, a high-income country, and you talk about finances and spending hundreds of billions of dollars on spine care. But when my wife and I, Joan and I, travel the world, it becomes very personal. For example, when we were in Tanzania, we were visiting a small village, and there was a clinic there, and somebody there must have heard that I had an interest in spinal problems. We arrived there just to kind of look at the village, and there were 35 people waiting in the clinic just to be seen. Another time, Joan and I were traveling in India, and we were in a small town in Rajasthan. And the owner of this little resort we were in said, "What do you do?" And I said, "Well, I'm interested in spinal disorders and spine-related disability." And he immediately wanted to have a clinic there and insisted that we spend part of our time visiting the clinic. Another time I was in Dominican Republic in the small town of Mocha, and just walking down the street, a car drives up and calls her when I say, "Here, you're interested in back pain." I can't get any treatment at all, and found out he was actually paralyzed and had spine surgery for a fracture of the spine. And then we arrive at the hotel, and the owner of the hotel takes out his x-rays to show me, because he had heard that I was interested in spine problems. In each of these locations, we have looked then at the medical community, who are very dedicated people. But I found that in almost all the communities we have, what they tend to do is simply have a patient, if the patient complains of back pain, they stay on the other side of the table, they're not examined, and in 1 to 5 minutes, they are handed a prescription. There are virtually no treatment at all. Given the fact that this is such an important thing, and there's such a demand in the world, and that the medical and healthcare community are simply not dealing with it, are not educated, not trained, not competent, do not have the resources to deal with it, made it evident that we needed to have a charitable NGO, or at least some mechanism to teach. So the goals of World Spine Care, therefore, are, first of all, to educate and to participate and to provide the background and the services for on which countries can build their spine care programs. Secondly, to where we can and where such facilities are not available, such as the small villages in Dominican Republic and Botswana, we actually provide volunteers, and we're so thankful for Stephen and others we've had over 50 volunteers at our various clinics. And the third thing we do is research and trying to find out how we can improve the care and how we can reduce the disability associated with pain and musculoskeletal and spinal disorders. If we can even make a small impact on these, in these three areas, I think we would have been successful as an organization. Our thanks go to the Skoll Foundation, who have been one of our primary sponsors, and we're so thankful to them. Thank you, Margareta.
Thank you, Scott. So we are now going over to the second round of questions for the panel. And the first questions go to Pierre again. If spine disability is such a problem for the healthcare system in high-income countries, why haven't they found a solution? Do you think that over-treatment, or do you think we treat the wrong items? Please have a few remarks on that.
Thanks, Margareta. So what I might tell you may seem to be counterintuitive. Even though high-income countries have invested a lot of money through our healthcare system and other ways to fund healthcare, lots of money in the past 10 years, we have not found a solution. In fact, if we looked at the data in my own country in Canada and we compare low back pain disability in 2007 to what it was in 2017, we see that it increased by 11%, despite spending millions of dollars on the rehabilitation of low back pain. If we look at the United States, we see a very similar trend. Between 2007 and 2017, the rate of low back pain disability has increased by 12%, despite billions of dollars in investment. So truly, what we have done in terms of managing low back and neck pain has not worked. And we really try to understand that when we develop the Global Spine Care Initiative care pathways, because if we have to, quote unquote, help other nations to solve the problem, we have to learn from the things that we did not do correctly. So let me list a few of the things that we think has contributed to the continued increase in disability, regardless of the amount of money that we've invested. Well, first, there's very few ways to prevent back and neck pain. There is some evidence that exercise and education will prevent a little bit, but they're not magic pills. So before back and neck pain develop, it's actually very hard to decrease the incidence or reduce the burden. Second, I've discussed in my initial discussion that back and neck pain is really a biopsychosocial issue, the disability related to it. Yet, most of the treatments that we provide for back and neck pain are traditional medical and rehabilitation interventions. So while it may focus on body functions and body structures, it basically ignores the aspects related to activity limitations and participation in normal life. So I think that we really have to shift our emphasis from clinical care more to a community inclusive type of rehabilitation. Third is that we still are using treatments that do not work. If you travel the world, low and high income countries, there are interventions that are provided to patients that have been demonstrated not to benefit patients, yet we still pay for them and we still deliver them. And I think that that's a major issue with our inability to bend the curve, so to speak. Second, and this is a problem in Canada and the United States, we tend to overtreat patients with back and neck pain. So someone has acute back or neck pain or even chronic, we keep on bringing them to the clinic, focusing on the biomedical model of treatment and rehabilitation instead of really embracing the full biopsychosocial model. So we treat a lot, and we often treat with interventions that have very, very little or no benefits. And the last thing that I think has contributed to the growth of the burden of back and neck pain is, again, as I mentioned and Jan mentioned earlier, back pain and neck pain do not occur in isolation. They're highly correlated with mental health problems and with other comorbidities. Yet, the intervention that we provide typically focus on the spine ignoring the comorbidities related to back and neck pain. And these are important sources of disability. So to conclude, I think that we have to learn from our lessons. Throwing more money into the medical system is not necessarily the solution to the problem, but we have to empower patients and communities to help people cope with their pain and disability so that they can engage in their normal activities. Thank you, Margareta.
Thank you, Pierre. And we follow up with a question to Jan. What are the concerns about implementing current high-income pain and disability pathways or treatment approaches into low-income countries? Please comment.
Well, thank you. And I'd like to pick up where Pierre left off, because it's actually pretty obvious after his excellent contribution here. But let's focus maybe a little bit more specifically on what it is we do in high-income countries, what the types of care that is so prevalent. And that's what I would call expensive but low-value care that consists of a lot of imaging and testing and specialist referrals that has been shown to really not promote good care and tells us very little about what is wrong with the patient and what they need to get on with their life. It's pharmacological treatment that has been shown to be largely ineffective for most back pain. And in fact, much of pharmacological treatment is harmful to patients. And the opioid epidemic that we're experiencing is a very good example of that. Yet that is being prescribed and provided to patients everywhere on a very frequent basis. And finally, many of the invasive procedures, the surgeries we see that are so prevalent, and in spite of very little evidence that they benefit patients to any great extent. Now, good research and also guideline recommendations point to other types of care as being more helpful, and that is encouraging patients to be active and at work, promoting self-management, and if you treat patients, then use low-tech treatments that can be provided in the community and that really don't cost very much. Yet these guideline recommendations and this evidence is not being implemented in our high-income countries. So you ask me, what would go wrong if we transfer this model of care and these therapies and this testing and this imaging to low-income countries? Well, we are going to experience exactly the same as we see in high-income countries. We are going to see a lot of ineffective care and rising disability. And this is disastrous in countries with poor or weak healthcare systems and very few healthcare resources. If they begin to spend their few healthcare dollars or money on these types of treatments that will not help the people with back pain. I communicate quite often with a back pain researcher from Nepal, and he tells me that a Nepalese worker with back pain must pay what's equivalent to 2 months' salary for an MRI scan. Yet you see people in Nepal walk around in the community asking people to contribute money so they can have an MRI scan to figure out what's wrong with their back. And then when they get the MRI, it's useless because it doesn't tell them what's wrong with their back. And these are the types of things and wasting of healthcare money, wasting of people's money for low value care that we see emerging in low income countries and that we just need to prevent. And that's one of the big values, I think, of organizations like World Spine Care and similar initiatives. That is not a way to proceed. Thank you.
Thank you, Jan, for this. We go now to Vincent. What is the current healthcare status and treatment options for people with pain-related disability in the low-income communities in Botswana? Can you tell us a bit about that? You may have to unmute yourself, Vincent.
Yeah, thank you for the question. It depends on the level of training of the person who sees the patient. Usually, if it's a nurse or a junior doctor, somebody comes in with back pain, they'll do some examination, and usually they won't find any signs. And then they will end up giving this patient some painkillers, different levels of painkillers. And it is not uncommon that an X-ray will be asked for. And some of these young doctors will even be very adventurous and order a CT scan, MRI, or yeah, some of these tests. But the higher level doctor may just advise the patient that they should continue in their daily activities after examination, of course. And in most cases, they will ask the patient to continue with their usual activities, give a painkiller. Painkillers are quite helpful. Having had back pain myself, they are quite helpful. But going to the level, doing even ordinary X-rays is not very helpful in most cases, because in most people, you'll take an X-ray, even in well people who don't have any back pain, and you'll find something wrong with the spine. So to answer your question, really, it depends on the level of training of the doctor. And I'd like to go back to what has been raised, the biopsychosocial approach to patient care. There are many people who will come in complaining of back pain. And when you really dig into their social lives, their environments, and so on and so forth, quite a number of men have got erectile dysfunction, but the red flag, the thing that they want you to, that they bring to you is, I've got back pain. And if you dig, then you'll find that really it's not back pain per se, it's that they have erectile dysfunction. Women who suspect that they have an STI, sexually transmitted infection, sometimes do come in with low back pain, even if they've been treated several times. And yeah. So I don't know if I've answered your question. The treatment that we give in the primary healthcare setting really will depend on the level of training of the healthcare worker.
Thank you, Vincent. You point out something that is important, that back pain can hide other problems, certainly. So the next question goes to Rajani. Do people in remote villages in India have access to evidence-based care? And if not, why not? If you can comment, please.
Yeah, the people in the remote villages in India do not have access to evidence-based spine care. The scenario is not very different from what Vincent described. That the reason is that there are lack of clinicians who are trained in evidence-based spine care to be able to triage and refer at primary healthcare level. People with spine pain in remote villages would typically seek care at the primary healthcare center, where there is a medical officer who delivers care, and medical officers are not trained in specific evidence-based spine care. So the regime of treatment would be very often anti-inflammatory drugs, and in severe cases, there would be a radiograph which is requested. However, following from the radiograph, we do not have an evidence-based care that would follow. So pretty much similar. However, some states in the country have started recruiting physiotherapists who are slightly better off trained than a medical officer to offer spine care. but that's obviously not enough for 70% of 1.3 billion people who live in rural India. So all in all, there is a strong need to train clinicians in evidence-based spine care. We would see a huge task force emerging with the help of World Spine Care, of primary spine care practitioners who, in a resource-constrained setting in a country like India, who can detect these red flags at an early stage before the patient develops a non-reversible disability, because that is what matters to these workers, these people in the remote villages, that they're able to return back to work, because that does not influence their own health-related quality of life, but it impacts the income of the entire family, because there may be typically only one breadwinner in the family in that age group, which is commonly affected, which the other panelists have mentioned. So on one hand, in the world, we're talking about spine pain being overtreated, whereas on the other hand, we have just not addressed because people do not seek care until it interferes with functioning, either in daily life or at work. And secondly, the reason why they do not have access to is probably because the healthcare system is not informed by large population-based studies about the impact of pain and disability that can give a clear picture of what is the magnitude of this impact and what is the nature of this impact on functioning of people. So we need to start at that very root, is to get started with these kind of population-based studies in the 4 zones of the country, because although India is a country, it's a continent in itself, and trying to investigate this across the 4 zones would be useful to first paint a picture of what it's like, and then get to the root of how it can have any influence on our healthcare system to provide care. Thank you. I don't know whether that answers.
Thank you, Rajani. It does. It gives you a perspective from India. Our next question is for Stephen Lasky. What are the challenges in introducing an evidence-based spine care into an underserved low-income community? Can you give us some personal experience, please?
Thanks, Margareta. So again, I think there are several challenges that we encounter when trying to introduce a new system or evidence-based spine care from both small and large levels. From a smaller perspective, one that I've kind of run into on the ground is just the simple dissemination of information about what programs like World Spine Care actually do at the hospital level. There tend to be a lot of staff throughout the hospital who are always aware of our presence in the hospital, but not having a full grasp or detailed comprehension about what services we actually provide to the patients we see at the clinics. And this is something that usually needs a regular amount of attention, whether it ends up being in informal hallway conversations with other providers you tend to refer to commonly in the hospital, or other local community providers that tend to refer patients over from some of the smaller clinics to the district hospitals as well. So really just bolstering the information about the type of intake, the type of treatment, the type of system that World Spine Care really aims to build and connect with as many people who are close by is essential to what we're doing to make sure there's a consistency about the type of primary spine services that we're delivering. This was actually something that was recently highlighted by one of our local clinicians, Dr. Mufudzi Chiambakwe. He had a study published titled, "If I Was More Informed About What Exactly They Do, Perceptions of Botswana District Hospital Healthcare Providers About World Spine Care." And that detailed some of the feedback we had gained about the degrees of familiarity that local staff have about us. Another challenge that we consistently run into is just simply trying to provide an educational component to the healthcare clinicians and also to the patients. And it's challenging in the sense that, you know, we're trying to replace or improve the existing knowledge base. that they have for more informed, more current evidence-based practices. And this can be challenging for a number of reasons, partially because you might be going against the consensus or the familiarity of what someone's already used to treating in terms of someone's exposure to spinal pain. For example, there are routinely a number of patients that World Spine Care clinics manage who have received surgical management for conditions that are so far from being surgical when they were first being taken care of or being diagnosed. And now you have all these secondary complications coming from increased disability that are contributing to these patients suffering. Navigating challenges that are arising from a societal and cultural aspect are also things that have to be considered. Determining how to advise a patient on evidence-based practice relating to the importance of self-care, exercise, and self-management strategies can be difficult if there's already an existing basis or expectation for treatments to be done by the clinician, where it's really a focus on doctor-centered care versus a patient-centered approach that we're trying to shift from. So trying to push this in terms of having a patient expect to rely on the medications that we've mentioned that they're used to receiving or already anticipating having increased for their care, and pushing for the opportunity to get them on more patient education strategies, patient self-management and active care, and increasing their own self-efficacy, that they're able to manage their own conditions on their own when the majority of these conditions are not serious pathology, not progressive, and we're trying to avoid them from becoming more chronic and disabling, is really something that can go back and forth very quickly. At a larger level, one of the challenges we typically run into is creating a sense of buy-in that is not only actionable, but also consistent from the people you're collaborating with at a higher level, administration-wise, in the programs. This can be challenging in the sense that, the Botswana program has been around for nearly a decade at this point, just shy of that. So when programs first start up and we have these initial agreements to really foster the program and gain support for them, they will eventually change over time. And that's nothing that is unfamiliar to our program or other programs around the world providing charitable actions. It's all about learning and determining how to consistently keep this ball rolling in a positive aspect so a plateau doesn't get reached and programs end up stalling out in certain forms. This was something that was actually spoken to earlier this week in a presentation with the Skull Forum. It was titled Partnering Through Political Transition, Lessons from the Field. So learning how to constantly keep higher levels of government and administration and partnering organizations involved and creating buy-in is essential to the continued viability and success of programs like World Spine Care to help ease spinal suffering.
Thank you, Stephen, for these words. And the last question is to Scott. Again, what can we do to help reducing the impact of spine-related disability? And as you are the principal investigator of Global Spine Care Initiative, which is partly funded by Skull Foundation, can you elaborate a bit on this initiative?
Thanks, Margareta. It's easy when one has a panel such as this to become a little discouraged when you recognize that we are, at least in the United States and Europe and Canada, we're increasing our spending. We are dumping huge amount of money into a system that's actually resulting in a negative impact on society. And one of our things that we wanted to do, as pointed out by Pierre and Jan, is that we have, if we're going to try and impact this global #1 cause of disability, we've got to change our thought process. And we've got to think in terms of how can we improve not just our understanding of spinal problems, but also how we deliver care and how people perceive their spinal problem and how they perceive disability, so that we can then enter into the community and make a difference. With this in mind, we formed a global spine care initiative, which was 68 clinicians from 24 countries, scientists, clinicians, physical therapists, chiropractors, medical physicians, surgeons, all of which came together over a period of a few years to develop a model of care which is based primarily on triage. So only those patients who really need an MRI or an X-ray or a CT get referred for such studies. These are extraordinarily expensive tests. In Botswana, there are only 2 or 3 MRI scans in the entire country, and we cannot use those limited resources or demand that they be used for conditions for which the results of which are of no consequence. And as pointed out by Jan and others, it's not reasonable to ask a patient in Nepal to spend 2 months of their income. This person is already vulnerable and may not even have income. And all of a sudden we withdraw those funds that are used to support his or her family and to use them for a useless test. There's been this tendency in governments to want to build, when they talk about spine care, buy more MRI scans. They want to build surgical centers and advanced surgical skills. And they basically ignore what Stephen and Pierre talked about, which is moving into the community and developing a community-based program. Well, the Global Spine Care Initiative, which many, if not all of the members of this panel are part of, is working on a system whereby we can educate people, and there is a tremendous desire for education. When we went to Botswana a year ago to put on a conference, the conference was opened by the Minister of Health, and there were over 300 clinicians from Botswana present at the meeting, and not one of them left the hall during that entire time, during a 2-day, 16-hour presentation. The level of interest by the healthcare community, as I said, a very dedicated healthcare community in Botswana, to learn and to participate was really amazing. And we did the same thing in India, arranged by Rajani in Mumbai. And again, the interest and the involvement and the desire to learn is extraordinarily strong amongst healthcare clinicians. In the Global Spine Care Initiative, we're basically focusing more on, or we believe the focus should be more on community-based education and participation. So the World Spine Care Clinics all have an exercise and education component of it, and a community-based one to try and change perception of what it means to be disabled and how to reduce the disability. And then we have the necessity of providing care, because most people don't understand. Somebody has to teach them when they have these problems and educate them and provide some relief. So we focus on low-cost, low-tech treatment approaches, which is what Stephen has been doing in Botswana and Dominican Republic. And now where we're at is the Global Spine Care Initiative is now expanding to develop a large research study to look at how we need to implement and how we can implement an evidence-based spine care approach in various low-income communities. And Vincent and Rajani are chairing the sessions in Botswana and India. And we are then going to do a study on the impact and see if we can demonstrate just how strong a current scientific evidence-based approach to spine care how effective it is to reduce the level of disability and improve the welfare, productivity, and overall health of the communities where we serve. And if we are able to do this, we'll be able to expand, I believe, to more and more communities and provide an example of what a community can do. In this way, we can reduce the impact of spine pain and related disability, which, as pointed out, impacts the most vulnerable people in our society. And you take this vulnerable person and then you take away their resources and their ability to earn, and they become even more vulnerable. So I'm extraordinarily excited about the future. I'm very thankful to this team and the entire team at World Spine Care and the Global Spine Care Initiative. And I believe that we have an opportunity now to advance and to improve the health and welfare of some of the most vulnerable people in the world. Thank you to everyone here.
Thank you, Scott. As you can hear, we do exciting things at World Spine Care. And I'm now leaving over to Stefanie because we have some questions from the audience, and then we will be back again in a little while. So Stefanie, it's all yours.
Perfect. Thank you, Margareta. And thanks to all of the panelists for your thoughtful and informative answers to these questions. You've obviously spent a lot of time ensuring that we're all making the most of our time together. So we do have a few questions that have come in. Just a reminder that we have been broadcasting live on Facebook. And so therefore, I have a question that has come directly from Facebook. Asking, how can we help or be involved with World Spine Care besides monetary gifts? Now, Scott, did you want to take a crack at this question? And if not, I'm happy to answer.
Why don't you answer that, Stefanie?
Okay, I'll start and you can jump in. So thanks, Jason, for your question. And obviously, I think in listening to the discussion that's gone on today, I think it's evident that this is a really complex problem requiring really thoughtful solutions. And obviously World Spine Care has taken a huge step forward in trying to bridge some of the gaps that have been identified here. In terms of how a person who's interested in getting involved with World Spine Care can do this, we are very open to working with individuals to do really anything that we can to move our mission forward. So obviously, fundraising is an area that we are always looking for support in. And as Scott had mentioned, the Skull Foundation has been hugely supportive of our mission, and we're very grateful to them, but we recognize that there are many ways that people can contribute. One of the things that I think World Spine Care really struggles with is low awareness. And obviously this group, and those of you who are joining us here, are aware of World Spine Care, and you're here with us for a reason. But one of the things that we really hope to do by sessions like these is to raise more awareness of the problems that exist in low and middle income countries related to spine care, and to educate people on what World Spine Care's mission is, what we're trying to do, talking about the Global Spine Care Initiative. So I think, one easy way that somebody can help us to move our mission forward is to just help to raise awareness. So that can be ensuring that you're subscribed to our e-newsletters, following us on social media, reaching out to myself, or using the email address info@worldspinecare.org to try to figure out how you can connect the news from World Spine Care to your own networks. We also are always recruiting volunteers. So we currently have clinics that are running in the Dominican Republic, in Botswana, in India, and in Ghana. And so we continue, obviously, given where the world is right now related to COVID-19, those recruitment efforts are on hold at the moment, but our hope is that in the short to medium term, we will be looking for new volunteers to help us to staff our clinics. And so I think really just being connected with us is a great first step. The other thing that I'll mention is that we do encourage individuals who work within the spine care communities to help to support and raise awareness of the importance of World Spine Day on October the 16th. Combined with that, or in support of that, World Spine Care does run a promotion that we call Work a Day, where we encourage clinicians who focus on spine care to help to engage their patients, educate their patients on the fact that there are people in the world who are suffering from spine and neck pain and who don't have the luxury of having a clinician close by. And so any opportunity, I think, to any of you that are joining us today to spread awareness of the need for support to World Spine Care and this global issue, I think will really help to bridge those gaps. Anything else that the panel would like to add to that?
I think you've done well. I think you hit the main points. Thanks, Stephanie.
Perfect. Okay. So I do have another question here that I will put out to the panel. During the COVID-19 pandemic and the obvious burden on our healthcare system, what do the panelists feel the role of spine care is? And in particular, we're thinking of practitioners, so chiropractors, physical therapists, physiatrists, etc. So I will put this out to the panel.
I'd like to suggest that Jan start on this.
Sure.
Yeah, I'm happy to talk about this. Obviously, there's a hierarchy of priorities here. And the main priority for everyone at the moment is to prevent spread of this virus. And that means that many of the, and spine care automatically for a few weeks or a few months have to move down in the hierarchy of priorities. So clinicians who normally are in communities and see and help many people with spine problems should probably not do that at the moment. But that doesn't mean that they cannot be active in helping people who are in pain. And I think we are seeing a rise of very creative solutions. People are opening up for telephone consultations, video consultations, and I can say in my own country, Denmark, for chiropractors and physiotherapists, the national health insurance have implemented reimbursed video consultations for physiotherapists and chiropractors pretty much overnight. This is something that's been negotiated, we've talked about for years, and it was just impossible to get funding for this. But all of a sudden, I think within 48 hours, this just happened and it was implemented. And I think this is something that also holds promise for the future. Now, I also think that spine pain clinicians can help keep people away from hospitals, because hospitals have other priorities. They are attending to these very sick patients now, and for, in some instances, trying to save their lives. So people in acute pain, people with acute radiculopathy or disc prolapse, even healthcare workers who cannot go to work without because they have pain. It can be people in the military or law enforcement who are very necessary to keep society functioning in these unusual times. They may need treatment and care. And again, I can only speak from experience here in my own country, Denmark. Spine pain clinics are encouraged to remain open and help these few people and actually see them and treat them, and treat them, at least provide minimal treatment, taking into account all the precautions for sanitation and protection that you need to do. So when I speak to clinicians, they say that they see around 5% of the normal patient load, but that these patients are patients that are really in acute and intolerable pain, that are very, have high degrees of anxiety and concern about their pain, or who have vital functions in society that they cannot take care of unless they get help. So these are some examples of what spine care clinicians can do during this COVID-19 crisis, but primarily I think we can help by actually encouraging people to remain active, take care of their duties, their families and their children as best they can, and show them that they can do much more than they think they can do with spine pain. And maybe we can carry on and carry a little bit of that into the future with us when we care for people in our communities. That's my hope, at least. I hope that answers to some degree.
That's perfect. Thank you, Jan. And on that note, I just would like to launch a new poll just to get a sense from the rest of you here what your thoughts are on how COVID-19 impacts us as a community, I suppose. Just bear with me 1 second and I'm going to launch. Sorry. Oh, I've got technical difficulties here. I'll try it again in a little bit. Okay, so moving on to another question. One question that we have for Vincent is just a clarification question regarding the comment that you made about in Botswana, the difference between how less trained doctors operate, and in particular ordering more x-rays, versus the way that more trained doctors, the course of action that more seasoned practitioners use. And in particular, the use of painkillers and how, you know, the varying degrees of sort of understanding or experience with those doctors varies based on that. Does that question make sense for you, Vincent? Vincent,
You have to unmute. Vincent has to unmute.
Oh, can you unmute, Vincent?
Yeah. Okay. Yeah. Nurses and lesser trained doctors will tend to use more pharmacological treatment. They will tend to do more investigations than those who are better trained, those who have specialized in some, especially let me talk about family physicians here. Those are the people I think who will do, in my opinion, who will do less investigations and give less pharmacological treatment. But of course, if you go to a surgeon, anything that has got, says pain, they will think of giving pharmacological treatment, or they will think of a surgery. So when I was saying that the lesser trained will think more pharmacological and more investigations, I was thinking of these lesser trained healthcare workers vis-a-vis family physicians.
Perfect. Thank you, Vincent.
Yeah.
We don't appear to have any more questions right now. I just want to give our audience some time to throw any additional questions out to the panel, if there are any, and or if there are any panelists that would like to elaborate on any of the things that have been discussed to this point today. All right. Well, it sounds like, hopefully, for those of you out in the audience here, as well as joining us on Facebook Live, that hopefully you received some really great, thoughtful answers to some of the questions that were posed here today. I'd like to turn things back over to Margareta briefly.
Thank you, Stefanie. I really want to thank everybody on behalf of World Spine Care, the panelists. This has been excellent panels, and thank you for your time and for volunteering your time, because this is the first webinar we have. to support this initiative. And I also want to thank the Skull Foundation for hosting the 2020 Virtual Forum Ecosystem events. So with this, we are actually wrapping up this session. And I don't know, Stefanie, if you would like to say a few words about the recording, etc., before we end the session.
Yes, thanks, Margareta. And actually, Rajani has just said that she'd like to make another point. So please go ahead, Rajani.
Yeah, thank you for this. Basically, in a resource-constrained country like India, where the focus is largely on infectious diseases, on maternal and child health care, where we need to build a case for support for spine care. And that's where we think that our little venture at the Mahatma Gandhi Mission Institute of Health Sciences, along with World Spine Care, where we're trying to build a model which is a sustainable model, trying to draw in the resources from the teaching hospitals. And if that can be strengthened, basically that can be used as a resource to strengthen the government's address to non-communicable disease burden, of which spine care is a major one, then that can reach out to as many remote villages, the rural and tribal people in the country. And I don't know whether that's a kind of model that we would like to adopt in other countries as well, where the resources are constrained and where the national health policies have limitations in trying to spend on the much needed healthcare system. Thank you.
Thanks, Rajani.
Yeah.
And, oh, sorry, go ahead, Vincent.
Yeah, if I may add to what Rajani has said, even in Botswana, there is a need for training in spine care. And I think at one stage, I shouldn't say at one stage, I think there is a memorandum of understanding that is in place, that is being prepared between World Spine Care and the University of Botswana into the possibility of providing training as a Faculty of Medicine in Botswana. I don't know how far this has gone, but I think this is one area in which World Spine Care can improve spine care in Botswana.
Maybe I can just comment on this also. I mean, what World Spine Care is trying to do is to involve the teaching institutions in countries who are willing to do so that we can increase the people who have been trained, or the clinician who has been trained by the university in the local countries. And because we need to build a ground so that there is a ground for us, World Spine Care, to go to another country, so to say, right? So once we have set this up and we can continue, provide training, etc., but we are growing up the physicians, the physiotherapists, the chiropractors, the nurses, whomever is taking care of the back pain in that low-income community, because we think that it's very important that the homegrown clinicians are trained.
Thank you, Margareta. With just a few minutes left, we actually have one more question that's come in via our Q&A, and I just want to put this out. I think I'll throw this to you, Scott. What are World Spine Care's plans to engage community participants with the Global Spine Care Initiative?
Almost everything we do is very dependent upon engaging the community. What is clear from this panel, and most of us who are in the field know, that we cannot impose a treatment approach on any community. You have to have a community involved. And in most of the communities where we're in, we try with varying levels of success to ensure that when we enter a community and open a clinic, that the local community leaders, including the administration, which may include a leader or a chief in a village in Africa, a university, some of the other healthcare providers, we try and incorporate each one of them. As I say, this has had varying levels of success, and we're learning by our prior mistakes and trying to improve that every time we move forward. But it is clear that a spine care program cannot be instituted from above down. It has to come with close community participation and interaction. Disability in spine care is a community-based problem, and that impacts the community more than it impacts anything else. And so it cannot be relieved without having that engagement. We're trying. We're welcome. Anybody who has more ideas of how we can improve on that, of course, would be welcome to the discussion.
Thank you, Scott. And so just to echo Margareta's thanks to the panel, sincere thanks to all of you for joining us today. Huge thanks to the participants that are out there and those that are watching on Facebook Live. We were thrilled to see the interest, and obviously this means this will not be our last webinar event, so please stay tuned for future topics to come. In terms of next steps for this webinar, we will be sending out a recording to those of you who had signed up, including additional contact information for being in touch with World Spine Care. So if you do have thoughts, ideas, ways you'd like to get involved, I encourage you to please reach out to us. You can visit the website at www.worldspinecare.org. And we look forward to being in touch with you in some way, shape, or form in the future. And just a final thanks to the Skull Foundation and to the Skull Virtual Forum for hosting us and for making this webinar possible today. Thanks again, everybody. Be safe and stay well. We'll see you soon.
Bye-bye.
Bye.
Bye-bye.
Thank you.
Thank you.